Okay, guys. Hi. We're gonna get through a couple chapters. So we're gonna start on chapter 11. So honestly, a lot of these next coming chapters, I don't need you to know a lot about. Okay. So antifungal agents, your ATI book actually does a really good job at summarizing um, what you need to know and what is important. So, chapter 11 is just kind of going over the overview. What is a fungus? How does a fungus differ from bacteria? Sorry, I'm just trying to get comfortable because I feel like I'm going to be sitting here for a while. So how a fungus differs from bacteria. So it is composed of a rigid cell wall made up of various polysaccharides. The cell membrane contains ergosterol, and it has protective layers of the fungal cell that make the organism resistant to antibiotics. So antibiotics do not treat fungals or fungi, and antifungals do not treat antibiotics. So that is the gist of that. So, patients that are susceptible to fungal infections, this is always going to be your immune compromised patients. So, your patient that has AIDS, HIV, immune compromised patients, taking immunosuppressant drugs, patients that take immunosuppressant drugs for their transplanted organ, like undergone transplantation surgery. And then we all know someone with cancer. Chemotherapy destroys your immune system, and they're very susceptible to infection, bacteria, viral, or fungal. So members of the growing population of older adults, diminish protection from environmental fungi. It is part of aging and geriatrics. So systemic antifungals, these are drugs that are used to treat systemic infections. Remember, systemic is all throughout the body. Local is in one singular place, okay? So this is like having a fungal infection in your lungs, per se, would be systemic. And then a local fungal infection would be like athlete's foot, where you would use topical antifungal. So you always want a culture to be obtained to ensure that the right drug is being used. Patients should not be put on additional patients should not be put at additional risk for toxic adverse effects. So some antifungals, protozoals, they can be toxic to the human body at high doses. So you have to be careful. So azole antifungals, the indication is to treat systemic and topical fungal infections. They bind. Okay, sorry. Anyways, so they treat systemic and topical fungal infections. So these drugs can be IV or like a topical powder, topical cream, or anything like that. So, anyways, contraindications for antifungals are huge when it comes to hepatotoxicity. That's going to be like your main one. Specifically, ketoconazole. Ketoconazole. I need you to know that is contraindicated in patients that have endocrine or fertility issues. Okay, this is important. This is actually on page hold on. Okay, so on page 379 in your ATI book, chapter 47, it starts talking about mycobacterial, fungal, and parasitic infections, and the drugs that go along with it. So, on page 382, it starts talking about antifungals. There are two antifungals, well, one, two, three, four antifungals that I really want you to look at. The first one is amphotericin B. The second one is ketoconazole. The third one is nystatin. The fourth one, I lied, is miconazole. And the fifth one is fluconazole. Okay, so specifically, ketoconazole is extremely hepatotoxic. Okay, so you want to make sure that you are watching for jaundice, dark urine, clay colored stools. Okay, you want to make sure you have a baseline liver function study and monitor liver function monthly. Okay, and then if manifestations occur, notify the provider, discontinue the medication. Also, with ketoconazole, it has effects on the sex hormones. So for male clients, you have gynecomastia, decreased libido, and erectile dysfunction. And then for female clients, you have irregular menstrual flow. So it can screw up a female's cycle. So the nursing action is to advise clients to observe for these effects and to notify the provider. For amphotericin B, okay, it has a whole thing on here on page 382, and it really sums it up very nicely. So amphotericin B is an antifungal agent that acts on fungal cell membranes to cause cell death. Depending on concentration, these agents can be fungostatic, which slows the growth of the fungus, or fungicidal, which destroys the fungus. So they are indicated for the treatment of systemic fungal infections like candidiasis, aspergillus, cryptococcus, and mucormycosis. I don't need you to know those. The complications, a big complication for this is infusion reactions. So those infusion reactions include fever, chills, rigors, which is really intense, like shaking, and headache for 1 to 3 hours after initiation. So remember this, write it down, put a star. I don't care what you do, but I want you to remember it, that a test dose of 1 milligram of amphotericin B is infused slowly, so you can assess the client's reaction. You can pre-treat the patient with diphenhydramine, which is Benadryl, and acetaminophen, which is obviously Tylenol. And you can administer meperidine, dantrolene, or hydrocortisone for rigors. Dantrolene is the drug of choice for malignant hyperthermia. You haven't learned about that yet. You will. It is a reaction to surgical anesthesia, and the key drug for that is dantrolene. So another complication for amphotericin B is nephrotoxicity. So with this drug, you want to obtain baseline kidney function, so a BUN and creatinine. You want to follow that up with weekly kidney function tests. Okay. You also want to monitor electrolyte levels, especially potassium, and you want to administer supplements for deficiencies. Amphotericin B can also cause bone marrow suppression, so you want to obtain a baseline CBC and hematocrit and monitor weekly. So on page 383 under nursing administration, it really sums it up for you. Amphotericin B is highly toxic, should be reserved for severe life-threatening fungal infections. Infuse it slowly over 2 to 4 hours. You always want to do that 1 milligram test dose. And then under interactions, it also has aminoglycosides like gentamicin, streptomycin, and cyclosporines have additive nephrotoxic risk when used concurrently with antifungal medications. So you want to avoid using these antimicrobials when clients are taking amphotericin B due to additive nephrotoxicity. Okay, so it's super, super important. Azole antibiotics, so your ketoconazole, fluconazole, miconazole, those are all azole antifungals, increase the levels of multiple medication. Warfarin, sulfonylurea, anti-diabetic medications. So if these are concurrent, you need to monitor for toxicity. Okay, very, very important. The toxicity, sensitivity, bone marrow for these drugs are very taken orally is used for the treatment of intestinal candidiasis. This is true. Nystatin is used in its oral form for treatment of candidiasis. Nystatin can be swallowed. It can also be swished around in the mouth and swallowed. It can be swished around in the mouth and spit out. It all depends on the directions. So other antifungal drugs, we've already talked about amphotericin B a lot. We also talked about nystatin. The hepatic and renal toxicity, bone marrow suppression is very, very important. Patients taking amphotericin B, again, should not take other nephrotoxic drugs, which in your ATI book specifically talks about aminoglycosides like gentamicin, streptomycin, okay? Topical antifungals, these are for the treatment of a variety of skin and mucous membrane fungal infections. You do not want to put topical antifungals on open areas, okay? These is for closed skin or mucous membranes, not for open areas. Specifically, topical antifungals, if used in the vagina or in the anus, now remember, this is nursing, okay? So we do have to talk about these things. We have to talk about people's sexual activities, preferences. So if someone is using a topical antifungal in the vagina or in the anus, they have sex with their partner. And if their partner starts to have a burning sensation, rash, irritation, that needs to be addressed, and then they need to notify a provider. Okay, that is an adverse reaction. So, which of the following is considered a contraindication for ketoconazole? So, I specifically talked about this. Patients with fertility problems. Okay. Now, I would also argue that patients with hepatic problems, but I think that's under the caution list, but contraindicated with fertility problems because of the effect it has on the sex hormones. So this is a question where you're really looking at what is the most correct answer. Nursing considerations for patients receiving systemic antifungals. So this is your IV antifungals. Contraindications or cautions for a history of allergy, liver or renal dysfunction, pregnancy and lactation. Remember, we talked about renal and hepatic function test and CBC. You want to have a baseline for these labs, and you also want to follow up according to your ATI book. You want to follow up with weekly kidney function tests and weekly CBC and hematocrit. Okay. And then for ketoconazole, it talks about monitoring liver function monthly. Okay. For nursing considerations for topical antifungals, we want to make sure that we inspect the area where you're putting it. The color, the temperature, the evidence of lesions, make sure that we are treating it appropriately with the correct antifungal. This is taking a closer look at fluconazole. The other name for fluconazole is diflucan. This is for the treatment of oral pharyngeal, esophageal, and vaginal candidiasis. It is used a lot in vaginal candidiasis. So an adverse effect can be headache, nausea, vomiting, diarrhea, abdominal pain, and rash. I want to see if there's any important things in your ATI book that they talk about for ketoconazole. I don't think there is. But I also want you guys to look at the questions at the end of each chapter in your ATI book. Okay. Clotrimazole, this is another one of your azoles, okay? Topical, stinging, redness, urticaria, edema. If you're using it vaginal, you could have lower abdominal pain, urinary frequency, burning or irritation in a sexual partner, right? We talked about this. So you want to make sure that your partner is okay, and may need to notify a provider. So, a nurse is caring for a patient with a fungal infection. Which of the following would be considered an adverse effect of a topical antifungal? The answer is A, burning or irritation in the sexual partner. So when topical antifungal agents are taken as a vaginal suppository, adverse effects include lower abdominal pain, urinary frequency, and burning or irritation in the sexual partner. Okay, so that is the end of chapter 11. Okay, chapter 12 is antiprotozoals. Causes of protozoal infections include insect bites, most commonly malaria, and then ingestion or contact with the causal organism, which could be amoebas, giardias, and trichomonas. I am not going to get deep into identifying the cause of malaria. I don't think that's important for you to know. If you want to look at it on your own, you absolutely can. Signs and symptoms of malaria include they are related to the destruction of red blood cells and toxicity to the liver. And then the treatment aims at attacking the parasite at the various stages of its development inside and outside of the human body. So your antimalarials, you have quinine. This was the first drug that was found effective. It was stopped. The use was stopped for a while, but now it can treat uncomplicated malaria. We also have chloroquine, which is common, and then hydroxychloroquine, Plaquenil, which is also very common. Of course, the indication is the treatment of malaria. And the contraindications and cautions: known allergy, liver disease, alcoholism, pregnancy, lactation, retinal disease or damage, psoriasis, or porphyria. Adverse effects include CNS effects, immune reaction, GI, hepatic dysfunction, dermatological, vision changes. So those are really important. Drug-to-drug interactions. A patient who is receiving combinations of quinine derivative and quinine is at an increased risk for cardiac toxicity and convulsions. Antifolate drugs and hydroxychloroquine and drugs that lower the seizure threshold. That is very important. You want to make sure you know if your patient is on an anti-seizure medication, your patient is at risk for seizures, hydroxychloroquine is going to put them at a higher risk for seizures. Risk factors for protozoal infection include unsanitary crowded conditions and then poor hygienic practices, so not washing the hands, and then unsanitary. This could also be water, like water that isn't sanitized properly, where you can get these infections. We already talked about other infections. It could be amoebas, trichomonas, giardia, toxoplasmosis. Those are your most common ones. I specifically want to talk about metronidazole, which is Flagyl. Metronidazole is a very commonly used medication in and out of the hospital system. So, on page in your ATI book, starting on page 381, it talks a lot about metronidazole, and it really, I like the way that it like clumps it together. So metronidazole is a broad spectrum antimicrobial with bactericidal activity against anaerobic microorganisms. Okay. Treatment of protozoal infections. The therapeutic uses is the treatment of protozoal infections, anaerobic bacteria, antibiotic-induced C. diff can be used for C. diff. Most of the time it's not. Most of the time it's oral vancomycin, but that doesn't mean that there aren't other treatments for oral vancomycin, or for C. diff. Prophylactics for clients who will have surgical procedures for vaginal, abdominal, colorectal surgery and are at high risk for anaerobic infection. It is also used in the treatment of H. pylori in combination with tetracyclines and bismuth subsalicates in clients who have peptic ulcer disease. So, complications for metronidazole. For GI, nausea, vomiting, dry mouth, and metallic taste. That's a zebra. You don't hear that often. Metallic taste. Okay. It says to take the medication with meals to reduce the adverse effects. Another thing, darkening of urine. What is the first thing you're going to think of? Decreased kidney function, right? But no. On page 381 in your ATI book, it says client education. This is a harmless effect of metronidazole. So that's interesting. Usually dark urine would suggest that there is some type of kidney dysfunction, but not with this drug. Neurotoxicity and CNS effects. This is important. You want to notify the provider if manifestations occur, which include numbness of extremities, ataxia, and seizures, and you would want to stop the metronidazole as soon as possible. Pseudomembranous colitis. You want to discontinue the medication. Client education, monitor and report fever, diarrhea, abdominal pain, or bloody stool. Metronidazole is contraindicated within the first trimester of pregnancy. This next thing that I'm going to say is important. Under interactions, it says alcohol causes a disulfiram-like reaction, which includes facial flushing, vomiting, dyspnea, which is shortness of breath, difficulty breathing, and tachycardia. Client education, avoid alcohol consumption while you are taking this medication. That is a huge teaching point, okay? It does say it on the bottle for metronidazole, but like I said, this is a very commonly prescribed medication in and out of the hospital. You want to make sure that your patient is not consuming alcohol while they're taking this drug. Also, metronidazole inhibits the inactivation of warfarin, phenytoin, and lithium. So you want to monitor the PT, INR. You want to assess the phenytoin and lithium levels and adjust the dosages accordingly. Under nursing administration, it says hormonal contraceptive effectiveness is decreased with various antibiotics, and therefore it is recommended to use a backup method while using this drug. So when are antiprotozoal medication contraindicated? The answer is with CNS disease. We talked about neurotoxicity. So it is contraindicated. Contraindications are known allergies, pregnancy, especially in the first trimester, CNS disease, and hepatic disease. When should anti-malarial medications be used with caution? This is alcoholism. Anti-malarials should be used with caution in patients with liver disease or alcoholism, both because of the parasitic invasion of the liver and because of the need for the hepatic metabolism to prevent toxicity. And that is the end of chapter 12. I told you we are going to go through a couple of these really quickly. This next chapter 13, honestly, guys, I would really prefer not even to waste my time on it. It is not covered in your ATI book. It's about deworming, okay? And I would like for you to look at it on your own time because, like I said, it's not even covered under ATI. It is, yeah, it's not something I want to waste my time on. So we're going to skip over chapter 13. So what is chapter 14? Chapter 14 is anti-neoplastic agents, which is definitely important. Okay. So when it comes to anti-neoplastics, the most important thing is making sure you know that your patient is immune compromised. Truly. That is like the most important aspect. So chapter 42, which is page 337 in your ATI book. I'm really liking this ATI book, guys. All right, so cancer starts with a single cell that is genetically different from the other cells in the surrounding tissue, and that cell abnormally divides. It continues dividing, and they lose more and more of their original cell characteristics. So it is a regular cell that just goes rogue, okay? It starts doing stuff it's not supposed to be doing, and it just gets out of hand, and that's when you start getting growing a tumor. Okay, so anaplasia, this is the loss of cellular differentiation and organization, leads to loss of ability to function normally. Autonomy, this is when cancerous cells grow without the usual hemostatic restrictions that regulate cell growth. Loss of control allows the cell to form a tumor. So the cancer cell literally like takes over its own journey. Like, you can't tell me what to do. You can't tell me when to stop replicating. I'm going to do what I want, and you're not going to say anything about it. And then it grows and grows and grows and grows. Boom, you have a tumor. Metastasis, this is when cancer cells travel from the place of origin to develop new tumors in other areas of the body. So if you know someone that was diagnosed with breast cancer, and then they tell you that they now have metastatic breast cancer, that means that one of those breast cell cancer cells have migrated to a different part of the body. It could be in the bone, it could be in the lungs, it could be in the brain, but that doesn't mean that the patient now has lung cancer, right? It means that the patient has breast cancer that has now metastasized to the lung tissue, because it's not lung tissue, lung cancer, it's a breast cancer cell that has caused cancer in another organ. Okay. So then you have something called angiogenesis. This is abnormal cells release enzymes to generate blood vessels to supply oxygen and nutrients to the cells that contribute to growth. Cancerous cells rob the host cells of energy and nutrients and block normal lymph function, which leads to the loss of normal cellular function. So if you have ever heard that a tumor was very vascular, that means that it is undergoing angiogenesis, where it is creating its own vascularity, which is just scary. Causes of cancer. Causes are not clearly understood, but we do have some ideas. So there could be genetic predisposition, viral infection, constant irritation, and cell turnover. This definitely, when you think about constant irritation and cell turnover, I want you to think of examples like skin cancer. So if you're constantly getting burned and that burned skin has to heal and then regrow, shed, regrow, shed more than your typical skin cell life cycle, or GERD. Okay, so if you have a lot of esophageal acid reflux, so that can cause a lot of irritation and erosion within the esophagus. There's a term for it. It's called Barrett's esophagus. When you have that increased erosion, it puts you at a higher risk for esophageal cancer, because those cells are breaking down and regenerating faster than they're supposed to. Whenever that happens, you always have the risk of that cell going rogue, and it only takes one, which is really scary. Stress, lifestyle factors, environmental factors, and then mosaic factors. There are types of cancer. You have solid tumors that are called carcinomas or sarcomas. Hematological malignancies, which could be leukemia and lymphomas. So that has to do with your leukocytes, your white blood cells, or lymphomas, which is your lymph cells. So the mutation that occurs during cell division as the tumor grows. The cancer cells, they're big, they're weird looking, they're in different they're not supposed to be in these places, right? So they follow their own rules. Anti-neoplastic agents, they include alkylating agents, anti-metabolites, anti-neoplastic antibiotics, mitotic inhibitors, hormones and hormone modulators, cancer cell specific agents, anti-neoplastic agents that cannot be classified elsewhere. So which term is used to describe the process that occurs when cells lose their cellular differentiation and organization? That is anaplasia. Anaplasia is a loss of cellular differentiation and organization, which leads to the loss of the cell's ability to function normally. Okay, so in your ATI book, alkylating agents starts on page 434. You have nitrogen mustards, nitrosurias, and platinum compounds. I will let you know because of all of these different classifications and names. I'm going to let you know if I want you to know a specific drug name. Okay. So, indication is most useful in treatment of slow growing cancers. They react chemically with portions of the RNA, DNA, or other cellular proteins, vary in their degree of absorption. Let's see. So, under complications on page 344, there is a complication where development of resistance to alkylating agents is from decreased uptake of alkylating agents and increased production of enzymes that repair DNA. So a big complication would be bone marrow suppression. Almost all of your anti-neoplastics are going to cause bone marrow suppression. When we have bone marrow suppression, we have immunocompromisation. Okay. When your patient is immune compromised, they're more at risk for infection, whether that's viral, bacterial, fungal, it doesn't matter. Okay. They are at a higher risk for infection in general overall. So bone marrow suppression includes low white blood cell count or neutropenia, bleeding caused by thrombocytopenia, which is a low platelet count, and anemia or low red blood cells. So your nursing action is to monitor white blood cells, absolute neutrophil count, platelet count, hemoglobin, and hematocrit. Assess for bruising and bleeding gums because those are signs of thrombocytopenia. Okay? Client education, avoid crowds and contact with infectious individuals. Does that mean people that are immune compromised can't leave the house? No. We've all seen patients that we probably assume are cancer patients that maybe do not have hair. They look like they're undergoing cancer treatment and they're walking around with a mask and they're using a lot of hand sanitizer. That just means they have to be extra cautious. Okay. Okay. So, I thought recording this in my office, I wasn't going to have a ton of distractions, but I feel constantly distracted. So, anyways, alkylating agents. So, contraindications and cautions in pregnancy and lactation, known allergy, bone marrow suppression, suppressed renal or hepatic function, drug to drug interactions. You want to use cautiously with other drugs that cause hepatic or renal toxicity. Excuse me. In the ATI book, it only lists complications that are very specific to each drug. Um, and with cisplatin, concurrent use with aminoglycosides can increase the risk for renal toxicity. And also, concurrent use of furosemide can increase hearing loss. So, do not use them together. Nursing administration considerations, you want to encourage adequate fluid intake of 2 to 3 liters a day. Monitor for blood in the urine. Reduce the dose for clients who have liver disease, monitor for bleeding, bruising, or infection, which could include, fever, sore throat, other signs of infection. Monitor CBC, uric acid level, liver enzymes, give antiemetics for nausea and vomiting, stop chemotherapeutic medications if extravasation occurs. You're not in front of me, so I don't know if you know what extravasation means, but extravasation means when a toxic medication infiltrates a vein. So when that medication leaks into the subcutaneous fluid, and damages the skin. So this can happen in very mild, or it can also happen severely. So extravasation severe can end up with a limb amputation. A mild reaction is just like, hey, maybe you should use some ice or warmth. By the way, one of the first people that you call when you have an extravasation is a pharmacist, because a pharmacist has all the information you need for what to do when an extravasation occurs. So let's move on. Sites of action of cell cycle specific anti-neoplastics. So this is talking about anti-metabolites that inhibit the DNA. This is talking about mitotic inhibitors that prevent mitosis. So this is the phases of a cell cycle and where that stops the actual reproduction of that cell. So anti-metabolites are on page 'em I'm getting to it. Antimetabolites is on page 337 where the chapter starts. So the select prototype medication is methotrexate. Methotrexate, which is a folic acid analog, this is a very common medication, and also has big complications with immunosuppression. So methotrexate can be used for chemotherapy agents. It can also be used for autoimmune diseases. Okay. So complications, number one, bone marrow suppression, low white blood count, which is neutropenia, bleeding caused by thrombocytopenia or low platelets, and anemia or low red blood cells. Monitor white blood cell count, absolute neutrophil count, platelet count, hemoglobin, and hematocrit. Assess clients for bruising and bleeding gums. Client education, avoid crowds and contact with infectious individuals, practice good hygiene. This is going to be on every one of these, okay, because they all decrease the immune response. Methotrexate specifically can cause mucositis, which is inflammation of the mucous membranes, gastric ulcers, and possible perforation. So we're automatically, especially with perforation, you're thinking about GI bleed. We want to monitor for GI bleed. What are signs of GI bleed? You have coffee ground emesis. You have black tarry stools. You want to assess the mouth for sores and provide frequent oral hygiene using soft toothbrushes and avoid alcohol mouthwashes. So the ones that like really burn inside your mouth, yeah, you want to avoid those. There is reproductive toxicity. You want to avoid becoming pregnant while taking this medication and for 6 months after. Methotrexate will abort your baby. Okay. Fetus deletus for sure. All right. Contraindicated in pregnancy and for 6 months after. So renal damage, this is due to hyperuricemia or elevated levels of uric acid. Monitor the kidney. INO, you want to encourage adequate fluid intake of 2 to 3 liters a day, and administer allopurinol if the uric acid level is elevated. Allopurinol specifically lowers uric acid and is usually prescribed for gout. Interactions for methotrexate include salicylates, other NSAIDs, sulfonamides, penicillin, tetracyclines. They can all cause methotrexate toxicity. Another interaction is folic acid changes the body's response to methotrexate, which it decreases its effect. So you want to avoid folic acid supplements or vitamins containing folic acid. And then they also have an interaction with proton pump inhibitors. You want to avoid concurrent use and monitor BUN and creatinine. So I definitely want you to be looking at methotrexate. All right, so anti-neoplastics is on page with methotrexate, I want you guys to look at page 340 under nursing administration. I want you to make sure you look at those, okay? Okay, so on page 346, there's a plastic agents. Let's see. So treatment of certain cancers, some break up DNA leaks, others prevent DNA or RNA synthesis and or repair. They're not absorbed well from the GI tract. Contraindications and cautions: known allergy, pregnancy, lactation, bone marrow suppression, suppressed renal or hepatic function, very important. Adverse effects: bone marrow suppression, leukopenia, thrombocytopenia, anemia, pancytopenia. What is pancytopenia? Pan means many, so that means you have a low amount of like all of your cells, okay? Red, white, platelets, everything. Mitotic, that is on it starts on page 341 in your ATI book. Most of it is on page 342. So you want to make sure you know that it is given IV. It is metabolized in the liver, excreted primarily in the feces. Adverse effects, always bone marrow suppression, thrombocytopenia, anemia, pancytopenia, GI effects, okay? So nursing administration, assess for indications of neuropathy, including weakness, numbness, tingling, foot drop, ataxia, paresthesias. Reduce the dose for clients who have liver disease. Assess breath sounds for bronchospasm. That sounds important. That sounds like a zebra. Monitor for bleeding, bruising, or infection. Monitor CBC and liver enzymes. Monitor for manifestations of gout. We just talked about gout. Practice good oral hygiene. Prevent pregnancy during treatment. Okay. Definitely look at all of these nursing administrative parts in your ATI book. So hormones and hormone modulators. On page 347, it starts hormonal agents with prostate cancer medications. And then the next one is hormonal agents with breast cancer medications. So for prostate cancer, complications for leuprolide, hot flashes, decreased libido, erectile dysfunction, gynecomastia. You want to teach your patient that this is a possibility. Decreased bone density, you want to increase calcium and vitamin D intake. There is a possibility of dysrhythmias, pulmonary edema. Nursing administration, you want to perform bone density testing, monitor for dysrhythmias, and assess breath sounds. Monitor the prostate-specific antigen, which is the PSA, and testosterone levels, which should both decrease with treatment. We already said decrease calcium and vitamin D. Monitor for bone pain. Prostate manifestations can worsen at the beginning of treatment, which is called the disease flare. This is all on page 348, and can be prevented by adding flutamide to the treatment. So flutamide is the next drug on here. It is administered like leuprolide or alone. Liver function should be assessed at baseline, and warn the clients of adverse effects of the medication, which can include gynecomastia, decreased libido, hot flashes. There are interactions. So you want to make sure if this patient is on oral anticoagulants or drugs that might increase serum lipid levels. So concurrent use of flutamide and warfarin can increase anticoagulation. You want to monitor a PT-INR. With degarelix, concurrent use with class 1A or 3 antiarrhythmics increase the risk for dysrhythmias or QT prolongation. So you want to make sure you are monitoring an ECG periodically. I hate when they put the question like before the content. So you're caring for a patient with a Wilms tumor who is receiving doxorubicin. What is an adverse effect of doxorubicin that you would teach the patient and their family about? So that would include red urine. Adverse effects of doxorubicin include cardiac toxicity, complete but reversible alopecia, nausea, vomiting, mucositis, red urine, myelosuppression, which is bone marrow suppression, fever, chills, and rash. Cancer cell specific agents. Wait, I want to go back to the hormone drugs because we didn't talk about breast cancer medications. So you have estrogen receptor blockers, monoclonal antibodies, and aromatase inhibitors. That starts on page 349. So I want you to look at the nursing administration on page 350, monitor for dysrhythmias and assess breath sounds, monitor CBC and calcium levels, monitor fluid status, monitor weights weekly and report weight gain, increase calcium and vitamin D intake, reduce bone loss with weight-bearing exercises, and then prevent pregnancy during this therapy. Tamoxifen can increase the anticoagulation with warfarin. Some of them have cardiac toxicity, tachycardia, heart failure, hypersensitivity reactions, vaginal bleeding, monitor bleeding and CBC, hot flashes. So I do want you to look at, specifically for these drugs, I want you to really look at patient education. Because obviously, if you're giving these drugs, you want to know about them and how they work. But I think it's really important because so many of our patients have cancer or have had cancer or know someone with cancer. And it's really important to understand the side effects and try to help your patients and educate them throughout this process. Okay. That's really important to me, and that should be really important to you as a nurse. Okay, so cancer cell specific agents, the goal of goal of much of current research is finding cancer specific drugs. Geez, oh Pete's. This would be more effective against particular cancer cells without devastating effects on healthy cells. There are available drugs out there. Many monoclonal antibodies have also been developed, and we're going to talk about those in chapter 17. We are not going to talk about this. Long-term effects, though, is important. Development of new cancers, bone marrow suppression, cardiac toxicity. Miscellaneous anti-neoplastics. So table 14.7. I am not going to go over those. I do want you, remember guys, I want you to look at the questions in the back of your book. I also want you to look at these questions in the back of your AT guidebooks, okay? All right. That is the end of chapter 14. Let's go to chapter 15. Okay, let's do chapter 15. We are not going to be using the ATI books for this one. Oh. So these are drugs that are acting, introduction to the immune response and inflammation. So we have specific defenses in our bodies that are there to protect us. And those include barrier defenses, cellular defenses, inflammatory response, and immune response. So an example of all four of those would be this starts on page 258 in your book. So barrier defenses are your skin, mucous membranes, gastric acid, and it's called major histocompatibility complex. This is the body's last barrier of defense, is the ability to distinguish between self cells and foreign cells. So that is called the major histocompatibility complex. Then you have cellular defenses, which are your cells, your leukocytes, which include neutrophils, basophils, eosinophils, monocytes, macrophages, lymphoid tissues. Then you have your inflammatory response. So I don't know if you guys have ever really gone in on your inflammatory response, but it is important to have an understanding of the inflammatory process. Sorry, I'm just trying to get organized. And we're going to get into that in the next couple slides. And then the immune response is your lymphatic system. So this is your T cells, your B cells, proteins, antibody formation. And then we have other mediators. So obviously, I just said all of this. Skin and mucous membranes, gastric acid, and then the major histocompatibility complex. Leukocytes, lymphoid tissue, these are your cellular defenses. You have your types of white blood cell. What here? See, it's starting. It's starting. You have types of white blood cells or leukocytes produced by the body. You have your actual white blood cells, which are your neutrophils, eosinophils, basophils, monocytes, your lymphatic cells. So your B cells make antibodies. Your T cells have 3 components to them. Then you have also your natural killer cells. So lymphoid tissue includes the lymph nodes, spleen, thymus gland, bone marrow, and the lymphoid tissue throughout the respiratory and GI tracts. The inflammatory response, this starts on page 260. The Hagman factor. Cell injury causes the activation of a chemical in the plasma called factor 12, or the Hagman factor. Hagman factor is responsible for activating at least 3 systems in the body. The Kinnin system, which is discussed here, the clotting cascade, which initiates blood clotting, and the plasminogen system, which initiates the dissolution of blood clots. So, the Kinnin system is activated when the Hagman factor activates kallikrein. It's a substance found in the local tissues, which causes the precursor substance kinogen to be converted to bradykinin and other kinins. Bradykinin was the first kinin identified and remains the one that is best understood. Bradykinin causes local vasodilation and changes in capillary permeability. So remember, permeability means that how easily or difficult are things passing through a cell membrane, okay? So if you have increased permeability, that means they pass through easily. If you have decreased permeability, that means it's harder to pass through. Okay? So, arachidonic acid stimulates the inflammatory response through activation of various chemical substances. You have prostaglandins, some of which augment the inflammatory reaction and some of them block it. You have cyclooxygenase, which is involved in inflammation and various protective actions in the body. You have leukotrienes, some of which cause vasodilation, increased capillary permeability, and some that can block the reactions. And then you have thromboxanes, which cause local vasoconstriction and facilitate platelet aggregation and blood coagulation. So this is all part of the inflammatory cascade, and it doesn't end there. So this just shows a picture of how it all starts. So it all starts with an injury to the tissue. There is a release of histamine. That release of histamine then cascades down into vasodilation, capillary permeability. You have loss of plasma proteins, and then you have swelling, right? Vasodilation leads to redness, increased blood flow leads to that area of the body feeling warm. And then all of these things lead to pain. And then on this side, you have exposure of plasma to the injured cells, which activates the Hagman factor, which falls into the bradykinin, which releases all of those chemicals, which all lead to the inflammatory response. Prostaglandins leads to pain. So true or false, a barrier defense that the body has is gastric acid. That is true. Okay. Histamine release. This is a locally mediated response. It causes vasodilation, alters capillary permeability. Neutrophils and blood chemicals enter the injured area, and they engulf and get rid of the invader or remove the cells that have been injured. So the histamine response is a very normal part of the immune reaction. But that's what leads to all of your signs of injury, like redness, warmth, and swelling is the histamine response. Chemotaxis and cellular phase of inflammation activated by the arachidonic acid. It stimulates neutrophils and macrophages to become very aggressive. So it's automatically in, I'm going to fight off this infection. Can lead to cell injury and destruction. So, excuse me, I have said this, and I'll say it 100 times. Inflammation can actually cause more injury than the injury itself. Okay, so is the inflammatory response a good thing? Yes and no. Okay. Yes, in the fact that we have it for a reason. It is a protective measure. But can it last so long or get so severe that it actually causes harm to the tissue? The answer is also yes. So you have acute inflammation that can last for minutes to a few days, which is protective. And then you have chronic inflammation that can last years and can be very harmful to the site of injury. So we did talk about these terms when we were looking at the chart. Calor is heat. This is all part of the histamine response caused by increased blood flow, so vasodilation. Tumor, they are referring to swelling in this case, caused by fluid that leaks into the tissues. I will not be using this term because I understand that it means this in the chapter, but I also do feel like the word tumor, especially when we're talking about anti-neoplastics, also is misleading. So you will not be seeing this word for swelling. You can see the word edema or swelling. Rubor is another word for redness, so RR, related to the increase in blood flow due to vasodilation. And then dolor, this is a term that you're most likely not going to see often. It's not used a lot within medicine, but it is another word for pain. So what factor stimulates macrophages and neutrophils to be very aggressive? So which part of the whole system, right? The answer is chemotaxis. So some leukotrienes activated by arachidonic acid have a property called chemotaxis, which is the ability to attract neutrophils and to stimulate them and other macrophages in the area to be very aggressive because you want them to fight off whatever is invading your body. So that is the end of the inflammatory response. And now we're getting into the immune response, which starts on page 262 in your big book. So this is a more specific invasion. I want this to move. Here we go. More specific invasion can stimulate a more specific response through the immune system. So this is more than just the neutrophil and macrophages like rushing to that site of injury, okay? So lymphocytes produced in the bone marrow can develop into T or B lymphocytes. Remember, B lymphocytes create antibodies, okay? T lymphocytes kill things, all right? Other identified lymphocytes include natural killer cells and lymphokine activated killer cells. These cells are very aggressive against neoplastic or cancer cells and promote rapid cellular death. So T cells, effector or cytotoxic T cells, they are found throughout the body. They are aggressive against non-self cells, so they can tell who belongs to us and who does not. You don't belong here, okay? They can directly destroy cells or mark for destruction and say, hey, I'm tagging you, I don't like you, and I'm going to send somebody after you. Helper T cells, it's all in the name, helper, stimulate other lymphocytes, including B cells, to be more aggressive, so more aggressive at producing antibodies. Suppressor T cells suppress or slow the reaction, so they allow the body to conserve energy and prevent cellular destruction from continued inflammatory reaction. So, having an active infection and having an active immune reaction is very tiring for the body. Okay, the sicker you become, the less energy you have because your body's cells are using all of your energy, your glucose stores in the form of ATP through your mitochondria, right? To produce as much energy as it can to fight off whatever is happening. So the role of the B cell, it is programmed to identify specific proteins or antigens, provide humoral immunity. When B cells react with specific antigens, it becomes a plasma cell. So it produces antibodies or immunoglobulins that react with specific antigens. They form antigen-antibody complex, activates the complement protein. So guys, do you remember in like science class where you had your little cells that had like triangle hats, and then you had your other cells that had like square hats? So an antigen is an invader, okay? It's a bad guy. An antibody is something that our body produces, that our B cells produce, that say, I've seen you before, I don't like your square hat, and I have something that fights you off because I've seen you before. This can happen from having an infection and building that response. This can happen from vaccination, whether live vaccination or not. This can happen, this can pass from mother to baby during childbirth. This can pass from mother to baby via lactation and breast milk. So there's a lot of different ways that antibodies can come and go into our bodies. Complement proteins, they react in a cascade fashion to form a ring around the antigen-antibody complex. They can destroy the antigen by altering the membrane, allowing an osmotic inflow of fluid that causes the antigen to burst. Induce chemotaxis, increase activity of phagocytes, and release histamine. Antibody formation. This takes several days. So once activated, the B cells form memory cells. Remember, they're carrying around their little hats, right? They're like, I recognize you. I know what to do with you. that will produce antibodies for immediate release in the future if the antigen is encountered. The antibodies are released in the form of immunoglobulins. We have many different immunoglobulins. They are for different things. We can use them also for treatment of different things. So we have IgM, IgG, IgA, IgE, and IgD. So these are all on page 263. By the way, these, like I said, these things can be given as medication. It's usually by IV infusion. That actually might be the only way, by IV infusion. So it says the first immunoglobulin released is IgM, which contains the antibodies produced at first exposure to the antigen. IgG contains antibodies made by the memory cells that circulate and enter the tissue. Most of the immunoglobulin found in the serum is IgG, so that's going to be like your biggest component. IgA is found in tears, saliva, sweat, mucus, and bile. It is secreted by plasma cells in the GI and respiratory tracts and in epithelial cells. These antibodies react with specific pathogens that are encountered in exposed areas of the body. IgE is present in small amounts and seems to be related to allergic responses and to the activation of mast cells. IgD is another identified immunoglobulin whose role has not been determined. We have other mediators. We have interferons, which prevent viral replication and suppress malignant cell replication and tumor growth. Interleukins, which are chemicals secreted by active leukocytes to influence other leukocytes. The thymus gland releases hormones that aid in the maturation of T cells. And then you have tumor necrosis factor, TNF. This is a chemical released by macrophages, and it inhibits tumor growth and can cause tumor regression. Okay. So the interrelationship of the immune inflammatory responses, they work together to protect the body and maintain homeostasis. The Hagman factor and histamine facilitate action of neutrophils. The helper T cells stimulate activity of B cells and effector T cells. The suppressor T cells monitor chemical activity and act to suppress the B cells and effector T cells. And both T cells and B cells depend on the effective inflammatory reaction. So it's literally just saying that when you have one, you have the other, and they're working together. Pathophysiology involving the immune system, you have neoplasms, viral invasion of cells, autoimmune disease, and then transplant rejection. Interleukin 1 stimulates T and B cells to initiate an immune response. What is another function of interleukins? I'm not going to ask you this. I'm not. But the answer is slow wave sleep induction. But I'm not going to ask you that. And that is the end of this chapter. Now we're going to chapter 16. Okay, so this is anti-inflammatory, anti-arthritis, and related agents. So the inflammatory response, we literally just talked about this. It protects the body from injury and pathogens, uses chemical mediators to produce a reaction that helps destroy pathogens and promotes healing. As the body reacts to the chemicals, produces signs and symptoms of disease. Occasionally, inflammatory response can become a chronic condition resulting in damage to the body. So, We have corticosteroids, which we have already discussed. They are used systemically to block inflammatory and immune systems, used topically to produce local anti-inflammatory effect. So corticosteroids are always going to have an effect on the immune system. The longer you take steroids, the more effect they have on the immune system. Antihistamines, these block the action of histamine. So that whole histamine reaction that we talked about blocks the action of histamine in initiation of inflammatory response. We have immune modulating agents, over-the-counter anti-inflammatories, which are going to be like your NSAIDs, and then all can cause adverse effects. Salicylates, this is your aspirin, okay? So the properties, aspirin has 4 mechanisms of action. They block the inflammatory response. They are fever reducing, which is an antipyretic. They are pain blocking, which is an analgesic. And then aspirin also is an antiplatelet aggregator. So it can be used in prophylaxis for MI, stroke, or DVT. So some of the oldest anti-inflammatory drugs are in this category. They are generally available without prescription, relatively non-toxic when used as described. And then someone who does not respond to one salicylate may respond to another. So salicylates include aspirin. And honestly, you probably will not recognize any of the other salicylates, but aspirin is available over the counter. The other ones, I would be surprised if you've seen before. Okay, but they are all in table 16.1 on page 271. And it lists all of them here. So therapeutic action and indications, it inhibits the synthesis of prostaglandin, which we talked about, which is in the inflammatory response. Treatment of mild to moderate pain, fever, numerous inflammatory conditions. The pharmacokinetics, they are readily absorbed from the stomach, peak level in 5 to 30 minutes, metabolized in the liver, excreted in the urine, which means they are going to be hepatotoxic and nephrotoxic. Contraindications, and I'm just going to say to aspirin because I'm not going to ask you about any of the other salicylates. So contraindications for aspirin would be a known allergy to salicylates, bleeding abnormalities, impaired renal function, surgery or invasive procedure scheduled within 1 week because it has anti-platelet aggregation capabilities. So if you're having surgery or an invasive procedure, you want to be able to clot normally. Adverse effects are a result of direct effects on the stomach and clotting systems, and also salicylate toxicity. I want you to know the signs and symptoms of salicylate toxicity, okay? Where is it? On page 274, under adverse effects, it says, salicylism can occur with high levels of aspirin, dizziness, ringing in the ears, difficulty hearing, nausea, vomiting, diarrhea, mental confusion, fever. But there's a difference between salicylism and acute salicylate toxicity. Now, acute salicylate toxicity may occur at doses of 20 to 25 grams in adults or 4 grams in children. Signs of salicylate toxicity include hyperpenia, tachypnea, hemorrhage, dehydration, excitement, confusion, pulmonary edema, convulsions, tetany, metabolic acidosis, electrolyte imbalances, fever, coma, cardiovascular, renal, and respiratory collapse. So salicylate toxicity is very dangerous to our bodies, and it will kill someone. So, let's see. I want you to know those. Let's see. I'm looking for something specific. Administer drug as indicated, check all drugs being taken for possible salicylate ingredients, monitor dose to avoid toxic levels, monitor for severe reactions to avoid problems, and provide emergency procedures, which include gastric lavage, induction of vomiting, and administration of charcoal. Administration of charcoal. Activated charcoal is the antidote for salicylism toxicity. Question 1. A person who does not respond to one salicylate may respond to a different one. That is true. Okay, NSAIDs. They provide strong anti-inflammatory and analgesic effects without adverse effects associated with corticosteroids. They are one of the most commonly used drugs in the United States. They are linked to increased risk of cardiovascular events and death, increased bleeding in the GI tract, and the choice depends on patients' personal experience and response. They may take several trials to determine the drug of choice. Some people like naproxen, some people like Motrin, some people want to take, let's see, we have phenoprofen, we have flurbiprofen, ibuprofen, ketoprofen, naproxen, oxaproxen. So obviously the ones we can get over the counter would be ibuprofen and naproxen. So the therapeutic action and indications, they are largely related to the inhibition of prostaglandin synthesis. Remember, prostaglandins do lead to that pain aspect and is in the inflammatory process or cascade, the inflammatory cascade. Contraindications and cautions if you have an allergy to any NSAID or salicylate. Celecoxib is also contraindicated in the presence of allergy to sulfonamides. Cardiovascular dysfunction or hypertension, peptic ulcer or GI bleeding, pregnancy or lactation, renal or hepatic dysfunction. So adverse effects include GI effects like nausea, dyspepsia, GI pain, constipation, diarrhea, flatulence, GI bleeding. GI bleeding is going to be a really big one with NSAIDs. Dizziness, somnolence, fatigue. You could have platelet inhibition, hypertension, bone marrow depression, drug-to-drug interactions. There's a decreased diuretic effect when it's taken with loop diuretics, so you wouldn't want to take an NSAID and like furosemide at the same time. Potential for decreased antihypertensive effective beta blockers, so it could decrease the effectiveness of beta blockers. It could increase lithium toxicity, especially when combined with ibuprofen, and then increase bleeding with anticoagulants, alcohol, or glucocorticoids. These are your names of medications. Again, on these propionic acids, the ones that you're going to recognize would be ibuprofen and naproxen. On this side, the ones that are the most common would be indomethacin and ketorolac, which is a very, very good IV NSAID. And can be very, very useful in pain relief. I want you to realize that it says NSAIDs up here, but I want you to understand that acetaminophen, which is Tylenol, is not, I want you to hear me, is not an NSAID. Okay? Okay, acetaminophen, therapeutic action and indication. It acts directly on the thermoregulatory cells of the hypothalamus, which means that it lowers your temperature when you have a fever. The mechanism of action related to analgesia has not been identified. Treatment of pain and fever associated with various conditions, including the flu. Prophylaxis of children receiving the diphtheria, pertussis, and tetanus immunization because it is painful. Relief of musculoskeletal pain associated with arthritis. So it is rapidly absorbed from the GI tract. It peaks in 0.5 to 2 hours, metabolized in the liver, excreted in the urine, which means it is hepatotoxic and nephrotoxic. You want to be very careful in hepatic dysfunction or chronic alcoholism because of the metabolization in the liver. We do know that Tylenol is basically the only thing you can take during pregnancy. So it is caution. It is not contraindicated in pregnancy. And then adverse effects include headache, hemolytic anemia, renal dysfunction, skin rash, fever. Hepatotoxicity is usually associated with chronic use and overuse. And then you have an increased risk of bleeding with oral anticoagulants, toxicity with chronic ethanol ingestion, which is alcohol, hepatotoxicity with barbiturates, carbamazepine, hydantoins, and rifampin. Remember, rifampin is that TB drug that I want you to know about that turns your urine, sweat, and tears orange. Okay. So on page 279, I need you to know that the maximum daily dose for most clients of acetaminophen is 4 grams. For some people with alcohol use or hepatic injury, a lower maximum daily dose should be used. Every year, children die from inadvertent acetaminophen overdose when parents give their child more than one over-the-counter drug containing acetaminophen or administer a high dose of acetaminophen. The Food and Drug Administration and drug manufacturers have joined forces to produce mass media ads warning parents about this possibility and to limit the amount of acetaminophen that can be used in each over-the-counter product. What is the antidote for acetaminophen, for Tylenol? I want you to know that. It is at the bottom of page 279 under adverse effects, and it says, when overdose occurs, acetylcysteine can be used as an antidote. Acetylcysteine is the antidote for acetaminophen. Hey, just want to make sure there's nothing I'm forgetting about aspirin or acetaminophen. Oh, here. I'm sorry to jump around. I do hate doing that. But for on page 274, under contraindications and cautions for salicylates, it says impaired renal function because the drug is excreted in the urine, chickenpox or influenza because of the risk of Ray's syndrome in children and teenagers. Okay. When are NSAIDs contraindicated? The answer is an allergy to salicylates. NSAIDs are contraindicated in the presence of an allergy to any NSAID or salicylate. Celecoxib is also contraindicated in the presence of allergy to sulfonamides. All right, anti-arthritis medication. Arthritis, or if you know anybody with arthritis, it can be very debilitating for people. So arthritis starts on page 280 and continues on page 282. So you have a gold compound, and this prevents and suppresses arthritis in selected patients with rheumatoid arthritis. Shortened is RA. Other drugs block inflammation and tissue damage of RA. So, on page 280, under therapeutic actions and indications, it says that gold salts suppress and prevent arthritis and synovitis. Gold salts are indicated to treat selective cases of rheumatoid and juvenile rheumatoid arthritis in patients whose disease has been unresponsive to standard therapy. This drug does not repair damage. It may prevent further damage, and so is most effective if used early in the disease. So the gold compound, I literally just said all of that. Contraindications and cautions. So it says gold salts can be quite toxic and are contraindicated in the presence of any known allergy to gold, severe diabetes, congestive heart failure, severe debilitation, renal or hepatic impairment, hypertension, blood dyscrasias, recent radiation treatment, history of toxic levels of heavy metals, and pregnancy or lactation. Adverse effects with gold salts are probably related to the deposition in the tissues. So stomatitis, inflammation of the mouth, glossitis, inflammation of the tongue, gingivitis, inflammation of the gums, pharyngitis, inflammation of the throat, laryngitis, the larynx, colitis, the colon, diarrhea, and other GI inflammation. A lot of inflammation with these gold salts. Bronchitis, pneumonitis, bone marrow depression, vaginitis, dermatitis. I mean, all the itises, all of them. Okay. DMARDs. DMARDs is a big one. DMARDs are available for treating arthritis. Many rheumatologists select DMARDs early in the diagnosis because they alter the course of the inflammatory process. So there are, let's see, what are my list of drugs? So anti-arthritis agents are in table 16.3, page 281. The tumor necrosis factor blockers, these are, if not all of them, yeah, all of them are either subcutaneous or IV. A lot of us, we've heard about Humira. We've seen a lot of commercials about this because RA is a autoimmune disease. That's why DMARDs are very popular. And they can be subcutaneous every other week. It could be monthly, it could be weekly. It just depends on the drug. This is what I was looking for. So DMARDs, there are two types of DMARDs discussed include tumor necrosis factor blockers, which are biologic, and others. Several DMARDs are discussed in other chapters, which include methotrexate, hydroxychloroquine, and many immunosuppressant medications. The adverse effects associated with these drugs can be severe to life-threatening because they alter the ability of the body to initiate or carry on an inflammatory reaction. So, under contraindications and cautions, these drugs cannot be used in anyone with an acute infection, cancer, sepsis, tuberculosis, hepatitis, myelosuppression, which is bone marrow suppression, demyelinating disorders because they block the body's immune inflammatory response and serious reactions could occur. They should not be used in pregnancy. Remember, methotrexate is fetus deletus, and you can't get pregnant during or 6 months after you stop methotrexate. The TNF blockers, the adverse effects include serious to fatal infections, lymphoma, and other cancers, MI, heart failure, injection site reactions. So these can be really, really dangerous. And we just talked about that. Boxed warnings about the risk of serious to fatal infections and development of lymphomas, which I just said. Drug interactions, immune suppressant drugs. You don't want to put your patient on too many immune suppressants. Live vaccines. If your patient is immune compromised, you do not give them live vaccines. Other DMARDs. Okay, anti-gout. We've already talked about one of them, which was allopurinol. Anti-gout hyperuricemia agents are on page 287. So these are drugs that either attempt to decrease uric acid or lower the blood uric acid levels. Therapeutic actions and indications may vary for drugs. So the most common medications in this classification is allopurinol and colchicine. Okay. So colchicine is for acute management of gout flares. And then allopurinol is more for chronic gout. Do you know where the most common place to have a gout flare is? It's really odd. It is the big toe. which is also called the great toe. Adverse effects. Colchicine can cause mild to severe GI distress. It is recommended to take with food and anti-diarrheal agents to help relieve the side effects of diarrhea. A provider needs to be notified if any severe reactions occur. Blood dyscrasias can occur due to suppressed bone marrow, so bleeding risks need to be monitored. Rhabdomyolysis is also, especially with long-term use. So that is the third medication that we are adding to the rhabdomyolysis discussion. Metformin, statins, colchicine are all linked to rhabdomyolysis. These drugs have a increased risk for renal calculi. So you want to make sure that your patient is adequately hydrated and getting 2 to 3 liters of fluid a day to make sure they're flushing out the uric acid from the kidneys and it's not accumulating within the kidney. Okay. Okay, chapter 17. Immune modulators. Okay, so immune modulators modify the actions of the immune system. The immune stimulants energize the immune system when it is exhausted from fighting prolonged invasion. Immune suppressants used to block the normal effects of the immune system, organ transplantation, autoimmune disorders, and some cancers. So, immune stimulants, we have interferons, which are naturally produced and released by human cells that have been invaded by viruses. They may also be released from cells in response in other stimuli. Interleukins, these communicate between lymphocytes, which stimulate cellular immunity and inhibit tumor growth. And then colony stimulating factors increase production of neutrophils in the bone marrow. So with interferons, therapeutic action, they prevent virus particles from replicating, they stimulate interferon receptor sites and inhibit growth. If you want to look at table 17.1, that just gives you a lot of different drugs. One that you have probably heard of are under the colony stimulating factors, which is filgrastim. Another name for that is Neupogen. And then the other one, pegfilgrastim, that is Neulasta. Those are both common colony stimulating hormones. So they're usually given subcutaneous or intramuscular. They have a rapid onset. They are contraindicated. Okay. I don't need you to know either of these meds. The colony stimulating factors, that is the Neupogen and Neulasta. So those are the most common ones in this classification. So you want to be aware of GI effects, headache, fatigue, generalized weakness, alopecia, dermatitis, generalized pain, bone pain, because it's stimulating the bone marrow, so they could have bone pain from that. Okay. So you are doing an initial assessment on a 55-year-old patient who is to receive aldesleukin, which we did not go over, and I'm not going to require you to know that answer. Immune suppressants. So you have immune modulators, T and B cell suppressors, interleukin receptor antagonist, and monoclonal antibodies. Immune modulators, these are very specific to their class, and probably the only one that you recognize is Otezla, because there's definitely like commercials out for Otezla, but a lot of them are they are not very common. So they do block the release of various cytokines involved in the inflammatory response and the activation of lymphocytes, which decreases the immune activity, especially in autoimmune diseases. So, one of the drugs is also contraindicated with severe hepatic impairment. Then you have T and B cell suppressors. CellCept is a big one. Prograf is a big one. Yeah. Let's see. Therapeutic actions and indications. They block antibody production by the B cells, inhibit suppressor and helper T cells, and modify the release of the interleukins. It's indicated for prevention and treatment of specific transplant rejection, as well as treating some types of arthritis. So the most important thing to take away from this situation is when you have a patient that is on anti-rejection medication for an organ transplant, it is imperative. It is so important that they are compliant with their medication regimen. Okay? They cannot just stop taking their meds. Okay? There's an increased risk for infection, of course, development of neoplasms, which is cancer, hepatotoxicity, renal toxicity, renal dysfunction, and pulmonary edema. And you don't want to combine these with other drugs that cause hepatotoxicity or nephrotoxicity. Interleukins. We don't really need to talk about these. They work to block the activity of the interleukins that are released. Live vaccine should not be given while on this drug. That's important. Anybody that is immune compromised, I've said it at least 5 times, live vaccines should not be given while taking immune compromising drugs. Monoclonal antibodies, we saw a really big use of these during COVID. Antibodies that attach to specific receptor sites developed to respond to very specific situations, like the COVID vaccine. They are all injected except for one of them, and they're processed by the body like naturally occurring antibodies. They can and usually cause fever with patients who have had a previous administration. The most serious adverse effects would be pulmonary edema and cytokine release syndrome. And this could be very dangerous, especially flash pulmonary edema. So that's something you definitely have to look out for. When giving a patient an immune suppressant, what must be monitored if the patient is also receiving gentamicin? This, we covered aminoglycosides. God, I feel like it was like 3 weeks ago. But specifically, I need you to know whenever gentamicin is listed, you're talking about nephrotoxicity. Okay, gentamicin is nephrotoxic. And that is the end of chapter 17. All right, let's quickly go over chapter 18 so that I can get this video out to you. So biologics, they stimulate the production of antibodies, provide preformed antibodies to facilitate an immune reaction, react specifically with toxins produced by an invading pathogen. So we have different types of immunity. Active immunity is the body recognizing a foreign protein and it begins producing antibodies to react with it. Passive immunity, there's two different types. There's passive artificial and there's passive natural. Passive artificial immunity occurs when preformed antibodies are injected into the system and react with a specific antigen. Okay? Passive natural immunity occurs when a person who is pregnant or lactating passes antibodies to the fetus or infant. So, what is a example of passive artificial immunity? Let's see. An example of this is when immune globulins are administered to a person to protect against a snake bite or rabies exposure. So this is when you are giving antibodies to someone, okay? Because remember, when we were talking about the immune process, antibodies take time. They take days to start working. If you got bit by a venomous snake, if you have tetanus, if you have rabies, you don't have days to wait for these things to start working. You need them to start working now, okay? Because in the meantime, you could die waiting for your body to make their own antibodies. Immunization, the definition is the process of artificially stimulating active immunity, exposes the body to weakened or less toxic proteins associated with specific disease-causing organisms. And the goal is to cause an immune response without having the patient suffer the full course of a disease. So the goal is for your body to make those antibodies so that when it is subjected to the organism or antigen, that your body already recognizes it and knows how to fight it. Childhood vaccinations, children routinely immunized against infections that were once quite devastating. Every year the CDC publishes recommended immunization schedule for the coming year. Recommendations change based on experience, exposure, and new developments. This is all evidence-based practice. The cost of vaccination can be a significant barrier to families. Most, if not all, vaccinations are covered, especially during pediatrics. Therapeutic actions and indications, they stimulate active immunity in people who are at risk. Vaccines needed depends on the exposure the person will have to the pathogen, and vaccines are thought to provide lifelong immunity. Most of them, not all of them, most of them hopefully provide lifelong immunity. So contraindications for vaccines, people of immune deficiency that prohibits the person's capability to make antibodies. Live vaccines during pregnancy is a no-no. Live vaccines if you are immunocompromised is a no-no. Delay vaccinations for patients receiving immune globulin or have received blood or blood products. Our blood that is circulating through our bodies right now have antigens, antibodies, all going through it, right? If I were to donate blood to you, I would also be donating my antibodies to you. Okay. So this could trigger a reaction. If you were carrying my antibodies, it could trigger a reaction within you if I have antibodies against that. Okay. I really hope that makes sense. And you want to use caution with a history of febrile convulsions or cerebral injury, any condition in which high fever would be dangerous, or an acute infection. You do not want to vaccinate if you are sick, if you have a bad infection or fever, okay? So vaccine adverse effects include fever, rash, malaise, chills, fretfulness, drowsiness, anorexia, vomiting, irritability, injection site reactions, and then rare is a severe hypersensitivity and CNS reactions, but it happens. It happens. Drug-to-drug interactions. Vaccines will not be effective if the drug suppresses the body's ability to make antibodies. And then with live vaccines, you could cause very serious illnesses if the patient is immune compromised or on immunosuppressive drugs. Vaccines and biological weapons. Anthrax, we talked about this the other day in class, actually. It was a very, very scary time. And people were literally scared to open their mail because anthrax was literally being sent in the mail. And it is available before exposure and for post-exposure emergencies. Smallpox is not really a thing anymore, but it is given to some military personnel, high-risk people. Tularemia, it's investigational live attenuated vaccine. The drugs are available after exposure. This is not a common thing. Botulism. Botulism is a huge risk for children under the age of 1 year old, which is why they are not allowed to eat honey under the age of 1 year old. Okay? I need you to know that. Viral hemorrhagic fever. The FDA approved a vaccine for Ebola, which is very nice. I don't know if you guys remember Ebola. It wasn't that long ago, but it was pretty scary. It was right when my nursing career started. And yeah, it was scary. So when are vaccines contraindicated? The answer is when a patient has received a recent transfusion. It is recommended to delay vaccination for patients who are receiving immune globulin or have received blood or blood products, as patients may not mount an appropriate immune response. Immune sera. In passive artificial immunity, antibodies are found in the immune sera. It may contain antibodies to toxins, venins, bacteria, viruses. There's antitoxins, which I talked about with tetanus. Tetanus is a toxin, so the tetanus vaccine is an antitoxin. It refers to the immune sera that have antibodies to very specific toxins that might be released. And then antivenom, which obviously is like spiders, snakes. So these provide passive immunity to a specific antigen. Like I said, if you got bit by a snake and you have that venom, you need an anti-venom immediately, and you need those antibodies now. You can't wait for your body to build up their own antibodies. So contraindications and cautions, history of severe reaction to any immune sera or products similar, and then definitely use with caution for pregnancy, coagulation defects, thrombocytopenia, and any previous exposure to the immune sera. You just want to use caution. So adverse effects related to the effect on the immune system: rash, nausea, vomiting, chills, fever. Of course, we all know what it is to have well, I hope you know what an anaphylactic reaction is, but difficulty breathing, severe hypotension, tightness in the chest, and then a local reaction, which is just at the injection site: swelling, tenderness, pain. We've definitely all felt that with vaccines for sure. So, true or false, immune sera are interchangeable for use against a variety of antigens. That is false. They are extremely specific to the antibodies for what they are fighting. And that's it. I didn't realize that chapter was so fast. So we have just completed like 7 chapters. I may or may not do another one of these videos for GI, but let me at least get this one updated or out, and then get some key points made. And yeah. Okay. Well, there's 7 chapters. See you later.